Good, welcome to Walk with the Doc. This is our June event, June 21st, 2017. There's a project where, and I believe it was in Sweden, if I remember correctly, where people who are having in the midst of, say, a cardiac arrest, and it takes a long time for the ambulance to get there. And as you all know from our earlier demonstrations last year, that having an AED is one of the most crucial pieces of equipment that you can have to help someone recover quickly and completely from a cardiac arrest. But what do you do when it takes a half an hour for the ambulance to get there? Anybody have any ideas if there's not a local AED to use? How would you get someone an AED quickly?
Chest compression.
Okay, but how about if you really, really need the AED? How would you get one to the people who are helping out with the cardiac arrest? Okay, but what's that?
Call Jimmy Johns.
All right. How about if a drone flies you an AED? Okay, this has actually happened in Sweden. So they can dispatch an AED by drone that can be there hopefully in a few minutes, much quicker than it would for the ambulance to arrive with the paramedics. So again, an AED, so make sure that you have your education to how to use an AED in case one drops out of the sky by a drone. So keep that in mind. So that's kind of the new wave of things. More on that later. All right, Dr. Wiemann's going to give us a broad spectrum discussion about the history of cardiology. By the way, he is retiring. For those of you who may have heard rumors about that, this will sort of cap off his 30th year as a cardiologist at Doylestown Hospital. I think he's counting down the days, and he'll tell you how many days he has left. It's been a great time working with Dr. Wiemann for 28 years. He's been a great mentor, a great partner, and a great friend, and he'll tell you more about his experience at Doylestown Hospital. Dr. Wiemann?
Because I'm old and retiring and talking about the history of cardiology, I'm going to use notes, because I can't remember any of this stuff. All right, these are some of the highlights. The 20th century is the century of heart disease and cardiology. Previous to the 20th century, we really didn't recognize many of the heart illnesses and catastrophes that we have today. People didn't live very long, and we had much more basic health needs before then. And as the health improved in the United States in the 20th century, heart disease became much more prevalent. And coronary artery disease is the #1 cause of death every year in the United States for both men and women. So it is still #1, although all-cause cancer has probably caught up and surpassed cardiology. So let's talk about some of the breakthroughs in cardiology that occurred over the last century. Many of these breakthroughs earned the Nobel Prize for the people that worked on them. First thing is the EKG. We kind of accept the EKG as having been around forever, and it hasn't been around forever. It is an invention of the 20th century, the earlier part of the 20th century. And in 1911, they first started using EKGs, which is electrocardiogram, or EKGs, which is electrocardiogram with a K, the German spelling of it. They're both the same. And the inventor of it thought it was a curious phenomenon to be able to record the electrical activity of the heart, but didn't really think this would parlay into any clinical utility. Einthoven, 14 years later, got the Nobel Prize for formalizing the EKG that we still use today. Next on the hit parade for the 20th century is preventive cardiology and the first Framingham study. So that was actually done in the late 40s, where a community was followed for 2 years in Framingham, Massachusetts. So we could really begin to talk about what are the risk factors for developing coronary artery disease. Since then, the Framingham data has been updated time and time again and has been mined for lots of great data to help us understand the risk factors for developing coronary artery disease and begin to impact those risk factors. One of which, of course, is exercise, which is why we're here today. The next development was learning the importance of cholesterol and lipids in the genesis of coronary plaque. And out of that has come dietary changes, again exercise, and finally the statins. The first statin was actually developed in 1976 in Japan, and its name is not pronounceable, but we have developed a bunch of statins later on. Today, atorvastatin, or Lipitor, is the #1 prescribed drug in America. That's not always a good thing. In my opinion, when you're the #1 drug, you're probably being abused by some group of people or prescribers. But nevertheless, that's how widespread use statins are. A very important development that developed in the 60s, which we take for granted today, is coronary care units. Specialized units within the hospital to treat patients with heart disease. And as we began to understand that when somebody has a heart attack, the #1 cause of death for these people is a lethal arrhythmia of the heart. And the way to treat that lethal arrhythmia is to recognize it right away and treat it right away with defibrillation. In order to do that, you have to be on a monitor. And in order to be on a monitor, you need to be in a unit that has monitors. Well, now every bed in Doylestown Hospital is capable of being a monitor, and if anything, we overuse it. But be that as it may, these specialized units were most important for recognizing early arrhythmias and saving lives. Echocardiography. Echocardiography is another tool that we take for granted these days. And echocardiography has had a slow evolution and development over many years, in fact decades. We were first able to see the heart using a technique of ultrasound or sonar to look at the structures of the heart and the flow of the blood through the heart. Since then, echocardiography has developed many, many new reiterations, including color flow Doppler, including 2-dimensional, including 3-dimensional echocardiography, including transesophageal echocardiography, and even intracoronary artery echocardiography. So these are all techniques that have developed, and the scientists and engineers have gotten better and better at giving us equipment so we can see ever more precise findings within inside the heart, not only in adults but in kids and even babies in utero. We can look at their heart and see if they have congenital heart disease. And that's even led to doing some surgery in utero on selected patients. Thrombolytic therapy. So once we finally understood that a heart attack was caused by a plaque, and then typically a blood clot forms at that plaque. When that plaque becomes unstable, becomes thrombogenic, a blood clot forms, and that is the straw that breaks the camel's back. That's what closes off the artery altogether. That's why aspirin is helpful as a preventive if you have coronary artery disease, because aspirin helps to prevent those clots from forming. So when we understood this was the mechanism in the majority of patients who have had a heart attack, we started using thrombolytic therapy. And the first drug we used for that was, anybody? Not Coumadin, that takes too long to work. Intravenous medicine.
Heparin.
No, heparin's not a clot buster. It helps prevent clots. It doesn't really break up the clots. Streptokinase is the answer. Everybody knew that, right? Okay. All right. We don't use streptokinase very much anymore. I thought there were a few more medical historians here. Okay. The next invention, so now we still use lytic therapy, and we use lytic therapy in many areas of the body. TPA is the most commonly used drug that actually breaks open clots. Coronary angiography and cardiac catheterization. So for a long time, it was thought that if you put a catheter inside the body in an artery and you touched the heart, you would die. That you would set off an arrhythmia or something and you would just die if that catheter touched the heart. A urologist proved that was wrong when he took a urology catheter. This was in about 1917. Put it in his own artery, snaked it down into his heart, and then he walked down a flight of stairs to the radiology department so they could take a picture and prove that it was in his heart. And that is the father of cardiac catheterization. Today we take cardiac catheterization also for granted. It's performed multiple times a day at Doylestown Hospital. And then the evolution of actually visualizing the coronary arteries by injecting the dye into them and taking a movie, now digital movies of that. Open heart surgery, another development that we kind of take for granted. First open heart surgery was performed in 1953, and this was closure of an atrial septal defect in a young girl. Now we do open heart surgery on people for all kinds of congenital abnormalities and acquired abnormalities such as coronary artery disease and valvular disorders. Many developments have been made in the field of open heart surgery, including the heart-lung machine, including hypothermia, and including improved surgical techniques. And today we take that very much for granted, but it truly was a breakthrough when this was developed. AICDs, automatic implantable cardio defibrillators. So these are the guys that treat those arrhythmias that we had when we had a heart attack, but maybe we don't get the arrhythmias right away after the heart attack. Maybe we get them down the road when we're no longer in the hospital. And if we have a lethal arrhythmia, ventricular tachycardia or ventricular fibrillation, we can wait for the drone to come down and bring us one. Or if we have one already inside our chest, we can be shocked out of the abnormal rhythm with no damage to the heart and essentially aborting the sudden death right away. A challenge has been to see who requires these devices, and we basically treat the patients who have had recurrent lethal arrhythmias that we've saved, and also people who have a low ejection fraction, a very low ejection fraction, less than 35%. And there may be some people here who have cardiac disease and a low ejection fraction, and we've put in an automatic implantable defibrillator. Maybe it's gone off, maybe it hasn't gone off, and we still will continue to use them, but this has really been a breakthrough. By the way, the guy who developed the defibrillator and the guy who had anti-tachycardia pacing, two giants in the field of electrophysiology in the United States, hated each other, and they would never agree to share their patents so you could put both anti-tachycardia pacing and defibrillating capabilities into the same shock box. I think they're both dead and the patents have expired, so now we have our modern technology. And then I guess lastly I'd like to talk about not just coronary angiography, but stents, angioplasty and stenting. So again, putting a catheter into the heart was thought to be lethal. It was thought to be even craziness to even think about engaging an actual coronary artery with a catheter. Well, now that's done routinely by our interventional cardiologists. Not only is it done routinely, but it's done quickly, because we know getting that artery open saves lives. And if lytic therapy was a breakthrough that we slowly dissolve a clot, and not always reliably, mechanically opening up an artery with an angioplasty and a stent is clearly the way to go. And Doylestown Hospital has distinguished itself by having superb parameters when we perform primary angioplasty and stenting. National guidelines would like to see an artery opened within 90 minutes of a patient getting to the emergency room with their heart attack, 90 minutes. And it does take time to evaluate a patient, get them to the cardiac catheterization lab, get the sleepy doctor out of bed and his whole team in to do the procedure. At Doylestown Hospital, we're not satisfied if it's over an hour, and we routinely get it under an hour. The rest of the world is beginning to catch up to us, but we're getting even better and better and better. And what makes this particularly effective in this community is all of you who are informed and who know the symptoms of a heart attack or a potential heart attack and get mobilized quickly, get to the emergency room, because that time is all important. We can't shorten that time by anything we do in the hospital other than discussing what are the signs and symptoms of a heart attack. We can shorten our time by the technology and the teamwork that we use at Doylestown Hospital. And that's a brief overview of cardiology.